Welcome, everyone. I'm Bruce Struminger with Project ECHO at the University of New Mexico, and just want to welcome you to the May 6th, 7th COVID-19 One Health update. And I'm going to give a few housekeeping and logistic updates before Dr. Jonna Mazet formally welcomes us. So we are trying to build a community of practice across Southeast Asia and the world with all of you who have joined us tonight. So we really want to encourage you to turn on your camera if the bandwidth allows, so that we can have a virtual face-to-face learning community session. But we do ask you to keep your microphone muted during the session. So camera on, microphone off, unless you're talking. Also, please rename yourself with your name and your organization so we know who you are and where you are and what your organization is. There's a chat function at the bottom of the Zoom screen. If you're having any IT challenges, please chat with ECHO IT and we will try to help you troubleshoot those. So we want to also use the chat for questions and comments. We don't need you to put your attendance in the chat. We're tracking attendance in other ways. In particular, we're trying to encourage everyone to use the PDA participant app. And there's a link and instructions on downloading that in the announcement. We will also put a link in the chat to help you with that if that makes it easier for you. And then once you've downloaded that and created your profile, you can scan the QR code to the right, and that's the start QR code for the session. And then at the end of the session, we will, 10 or 15 minutes before that, put up another, or right at the end, an end QR code. And then you will get a mobile certificate to your mobile device, attesting that you participated in this session, giving a description of it, and instant access to some of the PowerPoint presentations. All the presentation slides will be shared by email after the session, and so you should be getting those in the next day or two. We will also be recording the session, and your attendance is consent to be recorded, so thank you for that. We'll be making those available as well. And there will be continuing professional development credits available. And we'll put a link in the chat. They're through the University of New Mexico. We just need you to take 2 minutes to fill out a survey, which will help us get feedback from you about how to improve these virtual community of practice ECHO learning sessions on One Health. And we'll put a link to that at the end of the session as well. So with that, I'm going to stop sharing my screen and pass the microphone to Dr. Mazet.
Well, good evening here in the US and good morning in Southeast Asia, and good day to you wherever you are. It is my honor to welcome you all to our US Agency for International Development's One Health Workforce Next Generation ECHO platform. We're continuing to be thrilled with the participation, and I'm very happy today to be able to welcome you on behalf of our whole consortium, my partner, Professor Woutrina Smith, and you'll hear from our Southeast Asia One Health University Network Director, Dr. Vipat Kuruchittham, in just a minute. And I really think that we're doing a great service getting together and connecting and making sure, especially those of us who are academics, are helping to spread good fact and reduce concerns and theories that aren't based in fact for our communities. And that includes the disparities that we're, of course, suffering from and seeing in this, so highlighted in this tragic COVID-19 situation. We really are pleased to be able to talk specifically this time about gender and psychosocial issues. And so many of us are struggling with loss and with isolation and with sometimes threats on our own professional performance and you know, things that we wouldn't expect, trying to continue to do our good work, especially those of you who are pushing out all of the data and the science. So I welcome you all to share and participate, listen to our amazing panelists today, and to contribute through the chat box. And we'll have questions towards the end after our very esteemed panel has a chance to present and discuss with us. So with that, I'd love to hand it over for an ongoing welcome to my SEAOHUN partner, Dr. Pat.
All right, so good morning to all colleagues and friends from located in Southeast Asia, and hello to all the others for the rest of the world. The Southeast Asia One Health University Network, or SEAOHUN. We are delighted to co-host the session with University of California, Davis, and this consortium of the One Health Approach Next Generation with the support of the USAID. So this is now our fourth session, so it's very exciting that welcome for all who joining us for the first time, and welcome back for all the others. So actually, I had a chance to take a look at what we have been doing in the past three sessions. So I was so delighted to see that about 110 participants actually joined 2 of the last 3 sessions. So please coming back, and we look forward to really create a community of practice. So we'd like to hear from you. As Bruce mentioned, please give us feedback, suggestions of how we can be useful to you, or you have any particular topic that you like to present or to share. So really get to know one another as a community of practice. So today's sessions, as you heard, is going to be on the perspective on the gender and psychosocial aspect in outbreaks. And among the Southeast Asia side, the SEAOHUN happen to coordinate one of the studies of the psychological impact and on mental health on the COVID-19. So we have our colleagues from the Philippines going to present on that about the studies that they have found out. So with that, without further ado, I would like to pass it back to Woutrina to introduce the first speaker.
And I think tonight I'm doing that for her, so, or this morning for everyone, most of the people on. And so I'm thrilled to introduce you to Dr. Brian Bird, our One Health Workforce Next Generation lead for outbreak response and many other important activities. He'll give you the global context of COVID-19 and updates on COVID-19. Go ahead, Dr. Bird.
All right, thank you very much. It's great to be back with you, everyone. Let me just get the screen share sorted. There we go. Okay, so it's great to be back with you. This is our 4th session, so we've been doing this quite some time now, and I'm very pleased to be bringing you the big picture updates and some interesting things I found out about in the last 2 weeks, just for everyone's awareness. And just diving right into this week, we're at 3.5 million confirmed cases, which is actually 1 million more when I looked at the numbers than we were at 2 weeks ago. And I think this really pushes the message home that this pandemic is certainly continuing apace throughout the globe. And it's something we have to maintain our focus on. And I know many of you out there in the network are working on this, have been deeply impacted personally by this. I know that we have as well in my family. So working together, we can beat this thing and come out the other side. And across the SEAOHUN countries, we're now at about 32,000 countries. Something that came out in the last week from the WHO, IFRC, and UNICEF that I think is very applicable to this group, given the last few topics we've been talking about. We had a session on community-based surveillance, and then how to do public health outreach messaging. And this community-based healthcare guide that includes things on outbreak responses, how to do public health campaigns is very nice. It includes decision trees and other things that I thought were very good and actually applicable at all levels of engagement, from the smallest communities and villages up to big cities. So please check that out. As always, in my slides, the links to what I'm talking about are in the slides. So if you just click on it, it should take you there. The other thing that I wanted to bring out a highlight, we haven't touched on this yet, and we might in a future session of this platform, but is the economic impacts. And they are starting to become more and more pronounced. And it's something we also have to keep in mind. This is not only affecting our health, but also our economies. You know, and each country will have its own unique challenges. Every country is different. Every community is different. Because if you remember, I've talked before, all these outbreaks start in a community, but they also end in a community. So please be thinking thoughtful about your families, your communities, and the people you work with, about food, the jobs, how we're allocating healthcare resources, and very importantly, we can't lose sight of vaccination campaigns for other important illnesses like childhood illnesses and the like. And the tidbit on interesting things I found this past week, if you look at the site BioRender, the link is here on the right. If you click on that, you can go to a very nice vaccine and therapeutics update tracker that really in one place puts all of the latest information on the new vaccines that are being developed, where they are in their status of development, and same for therapeutics, so antiviral drugs or antibodies. And just to highlight that we're not alone in the struggle, the European Union had a challenge in the last few days to raise funds for development of vaccines and therapeutics and distribute those equitably, and they raised over 7 billion euros in just one day. So some promising things there on the point of countermeasures. This is just another screenshot from that tracker app. Again, the link is right there. I encourage everyone to look at it, and you'll get a lot of information that we don't have time to get into today. And of course, on my last slide is just a link of links to many websites that have important and informative information. And I'm really delighted to see this panel come together on gender and psychosocial issues. This is a critical thing, and I'm even more delighted to have one of my first academic colleagues, Dr. Sabra Klein, give a presentation. She really taught me a lot in this area, and I'm very excited to hear from her. And I'll turn it back to Dr. Mazet. Oh.
Wonderful. Thank you, Brian. So next I would really like us to welcome our head of our One Health Workforce Next Generation Gender Equity Lead. Professor Ndola Prata is just a staunch advocate and amazing academician in this field, and we're so lucky to have her as part of our team, and I know that she's put together a wonderful panel for you today. So I'll hand it over to you, Ndola.
Thank you so much, Jonna. It's a great pleasure to be moderating this session. I wanted to start by saying that it is important to realize that assessments of risk, prevention, and response to outbreaks must incorporate the lessons learned on the significance of gender in the spread and control of the epidemics. And our panelists today will speak to the significance of the sex and gender during epidemics. But before I introduce the first panelist, I wanted all participants to use the polls feature of Zoom to answer your first question of today. We'll have 3 questions in total. Jutta, can you please make the question available? Okay, so the question is there. So while you are answering the question, I would like to invite our first speaker, Dr. Sabra Klein. She's a professor of molecular biology and immunology at the Bloomberg School of Public Health at Johns Hopkins University. Welcome, Dr. Sabra.
Thank you. Let me share my screen. So the poll keeps popping up on me. Hopefully everybody can see this. Okay, so thank you. I am grateful to be here. I'm grateful for the organizers, and I'm grateful to have somebody specifically Dr. Brian Bird, who has just been, it's been wonderful to watch him from the time when he got his SCM at Johns Hopkins, now to being one of the directors of the One Health program there at UC Davis. So today I'm going to be discussing with you not just about gender, but maybe a little more broadly about both sex and gender. I am a biologist, and I do think a lot about how not only our behavior and the societal and cultural norms that shape us can impact our susceptibility to infectious diseases, but I also think a lot about how the biological differences between males and females can impact this as well. So just, I think, to start us off, to ensure that we're all understanding the differences in terminology, the Institute of Medicine in the United States published a report in 2001 entitled "Exploring the Biological Contributions to Human Health, Does Sex Matter?" And in this book, or in this report, they did a very good job making a distinction between sex and gender. Sex referring to the biological differences associated with being male or female according to our reproductive organs and our sex chromosome complement, whereas gender, which is going to be the focus of the remainder of this panel discussion, is really focused on one's sense of self as being male or female based on societal or cultural norms. And so just for clarification, I think it's important that we recognize these distinctions. But as I noted, I am a biologist, and I do think a lot about sex as a biological variable that can affect our immune responses to infectious viruses, such as the currently circulating SARS-CoV-2 virus. And it really all, these differences between men and women really all begin with our sex chromosome complement, with females having 2 X chromosomes and males having an X and a Y chromosome. On that Y chromosome is a gene entitled SRY that encodes for testis determining factor that leads to the development of a bipotential gonad into a testis, as opposed to an ovary. So both the sex chromosome complement as well as the differences in our reproductive tissues, females having ovaries, males having testes, contribute to the biological basis that I'm referring to as sex. Our different gonadal tissues secrete different concentrations of sex hormones, with the ovaries producing more of a hormone called estrogen, and the testes producing more of a hormone called testosterone. These hormones can alter through receptor signaling, sex-specific characters that can impact our immune system, but this is not to say that genetic differences between males and females cannot also have an impact. Both X-linked genes, and it turns out there are a little over 60 immune response genes on the X chromosome, as well as genes in the autosomes. So I just briefly point this out to give you a sense of where sex-based differences evolve from and how they might impact the functioning of our immune system. Now let's take a step back and talk about the current COVID-19 pandemic. So these are data from Global Health 50/50, which I do have an active link here in my slide. Pulling from data from this website, which is doing live calculations of sex disaggregated data worldwide, noting countries in green, which are countries that have not produced any sex disaggregated data. So there is still a need for countries to be reporting their data based on whether the individuals are male or female. In brown, we have countries that have complete sex disaggregated data, meaning they are sex disaggregating at least cases and deaths, with some countries disaggregating hospitalization. And then in this orange or yellow color are partially sex disaggregated data, meaning these are countries that are either disaggregating data for cases or death, but not both. In the stippled lines, so you see these lines going through some of these countries in brown and in yellow, these are countries that have also been sex disaggregating data from healthcare workers, which I think will become very important in discussions about gender and things like occupation and the fact that 70% of the worldwide healthcare workforce is women. When we look at the disaggregation of data for cases of COVID-19 around the world, what we find are that about 34% of countries are reporting a male bias in their number of cases, 45% are reporting a female bias, and 21% are reporting no bias. So in terms of cases, we're really in this moment concluding that there really does not appear to be that tremendous of a sex bias, if you will. Where we see a much greater bias is when we look at deaths from COVID-19, in which worldwide, 87% of the countries that are sex disaggregating data pertaining to COVID-19 deaths are reporting significantly greater mortality among men as compared with women. 2% of countries are reporting greater deaths in women, and 11% are reporting no difference between males and females. So this is quite a remarkable bias. To give you a better sense of what this looks like on a per country basis, here in panel A, we're looking at the case fatality rates by individual countries broken down by sex, blue being males, pink being females. And what you can see is that for the countries with the greatest numbers of deaths, down to the countries that have sex disaggregated data but have had the fewest numbers of deaths, you can see that regardless of whether this is Italy and the Netherlands, where the case fatality ratio is quite high, or South Korea, Thailand, where the case fatality ratio is lower, we still find significantly greater mortality among men as compared with women. In panel B, for a few of the countries at this website, we can actually see and look at data disaggregated not only by sex, but by age. And so here we're looking at the case fatality rates by age group. So these are broken down into 10-year age groups. And as you can see, a majority of deaths from COVID-19 are occurring in older aged individuals. So we do see a greater number of deaths with advancing age. But regardless of the age group, from 30 years and older, within each 10-year age group, there are more men dying from COVID-19 than women. There are several possible mechanisms for these sex and gender-based differences in COVID-19 pathogenesis. And I think we're going to hear extensively about some of the gendered variables pertaining to our lifestyles, seeking of healthcare, utilization, and in some cases, even access to healthcare. We may even hear from other speakers about comorbidities and how things like increased risk of heart disease or hypertension in men may be contributing to this differential outcome from COVID-19. But I do want to use my few moments with you to also point out that there can be epigenetic and genetic differences between men and women that can contribute to differences in COVID-19 outcomes. Hormonal differences, estrogen, testosterone can actually alter the functioning of our immune cells as well as the expression of receptors that the virus can use for entry into the respiratory epithelial cells. Virological differences, including early reports suggesting that there is prolonged shedding of SARS-CoV-2 in men as compared with women, as well as immunological differences in the innate immune system and our ability to recognize something foreign like SARS-CoV-2, to our antibody response, and even T-cell regulation. So I really just use this complex graphic to make the point with each and every one of you that this is going to be multifactorial and intersectional, involving both biology as well as behavior and lifestyle. To kind of further illustrate that sex differences in the immune responses to SARS-CoV-2 could play a very important role in contributing to the male biased risk of severe outcome from COVID-19, I'd like to point out that there can be differences between men and women in early virus entry, the expression of receptors ACE2 and TMPRSS2, both of which are necessary for viral entry into our cells, show sex-specific expression being greater in males as compared with females. The innate immune recognition of the virus by pattern recognition receptors like toll-like receptor 7 tends to be greater for females as compared with males. There can be differences in cell death, triggering activation of recruitment of immune cells, production of cytokines and chemokines, and this bidirectional feedback loop that can occur between those. The activation of our immune system is absolutely necessary for clearance of a virus, which females tend to do better. But this can also, if prolonged, lead to vascular leakage, damage, and severe respiratory infection, which we are hypothesizing could be worse for men as compared with women. The last point that I would like to make with you is that antibody production has been shown in the context of COVID-19 to be greater in women as compared with men, and how this may be contributing to better outcomes is something that my group is currently evaluating. I thank you for this invitation and your time. I'm very grateful for several of my colleagues. I would like to give a special thank you to Santosh Dakal. He received his DBM in Nepal, came to the United States for his PhD at Ohio State, and is now a postdoctoral fellow working with me. He is on this call and continues to give tirelessly to educating scientists in Nepal about the COVID-19 pandemic. I'd also like to thank the members of the Gender and COVID-19 Working Group for many of the wonderful, intellectually stimulating discussions that we have had. And with that, I will stop sharing my screen. Thank you.
Thank you so much, Dr. Klein. Really very insightful presentation. I would like now to present Dr. Brigitte Bagnol, second speaker. And Dr. Bagnol is from the Department of Anthropology at the Wits University in South Africa.
Good morning, everybody. I hope you are hearing me. So my name is Brigitte Bagnol. Thank you very much to invite me for this presentation. I was introduced as an anthropologist, and indeed I'm going to concentrate mainly on gender issue related to COVID-19, as the previous presenter introduced nicely the aspect related to sex. However, I just would like to again give basic definition about sex, which are the biological differences between men and women. And
Bagnol, I'm sorry to interrupt. Could I ask you to go to presentation mode? We're seeing the the presenter mode.
Like that?
That's perfect. Thank you. Sorry about that.
It's okay, thank you. So gender is, as my previous colleague said, the social relation between men and women, mainly power relation between men and women. Those relations change over time, change according to places, and also intersect with other markers of inequality, such as race, class, age, religion, education, and so on. In this presentation, we are going to see the impact of sex and gender on COVID-19 disease. This slide is a slide from WHO illustrating how sex and gender impact on human infectious disease. You see that gender relates to norm, to roles, and to decision making, and sex, as was introduced earlier, is related to anatomy, to the immune system, and also relate to the life cycle of men and women. Both sex and gender impact disease prevention and control program, which in turn are key elements and point of intervention for infectious disease transmission and outcomes. Gender and sex define vulnerability to disease, the response to illness, the exposure to pathogen, which in turn will impact on, will impact on the incidence, the duration, and the severity of the disease. We are observing internationally, as the previous presenter explained, a lack of data disaggregated by sex. However, we understand that a lot of countries disaggregate data and allow us to have some understanding of the situation. We understand also that people from marginalized and poorest groups are impacted worse than other groups. Data from England, by example, indicate that there were 50 deaths for every 1,000 people sick, compared to 25 people dying in area where there are people are wealthier. So we understand that COVID-19 magnifies existing inequality between people and between group of people. The people with lower economical condition being more affected and more likely to die of COVID disease than people coming from wealthy area. The data presented in this slide relate to the data previously introduced by the previous speaker, where you see that in relation to cases in different countries, we don't see a lot of differences between men and women. And when we look at the deaths, we can observe that there is a very clear tendency of male having an increased rate than female. As was explained earlier, sex interfere in the fact that women have a stronger adaptive immune response and die less of infectious disease during their entire life since birth, and that hormone plays a role on how bodies fight against disease, and also chromosome plays a role. If we look at gender issue, we will see that men and women multiply the prevention differently. Men might reach the health center when they have different symptoms from women, and men and women might have different comorbidity, by example, smoking or drinking, which will affect the outcome of the disease. Now I'm going to speak about how gender influences the socio-economic impact of disease and how the COVID crisis has a potential to widen gender inequalities. When we look at the data across the globe, we can see that women are participating in a very limited way in the decision-making around the program and the intervention related to COVID-19. By example, in Italy, women represent 20% of the leaders involved in the national response. If we look at data from UK or the US, we see also that the security response is mainly done by men. Data published by UN Women also show that internationally, the response is not gender sensitive. And some of the measures, like the measure of confinement, tend to increase gender-based violence. UN Women call attention for the need to involve women in the decision-making. Looking at who is taking care of sick people, we see that in the healthcare centers, in the healthcare institution, women represent 70% of the health staff internationally, and looking specifically at nurses, we have 90% of women taking up this responsibility. Very often, women are in a lower position and with a low salary. They are understaffed, there are sectors which are understaffed and are under-equipped and overexposed to the disease. During confinement, women play a very central role in the household. They have to assume most of the domestic and the caring role of children and sick people. We observe in many countries, inclusive in France, after the first 2 weeks of confinement, we observe an increase of 36% of domestic abuse in France. Another impact which is observed is that in case of economic crisis, women are more likely to be let out of job because they are often in insecure job position, low pay, informal work, and they are likely to lose their income due to the lockdown and the economic crisis. So if we can do some recommendation on ways to integrate gender, we need to look at several areas. We need to look at an area related to data and research. We need to ensure that data are disaggregated by sex and by gender, and analysis of any information is done with a gender lens, which it can be related to the psychological impact, the impact on treatment on men and women, including pregnant women. All those research, all those analyses need to be involving a gender analysis. In relation to decision-making, the call is widely to involve women organizations as much as possible, because due to their role in the health facility and at home, women have the possibility to give great contribution and orient for intervention that are gender sensitive. In relation to healthcare, it is important to value nurse and midwife activity and profession and give them safe and decent working conditions. We have been observing in different outbreaks, such as Ebola or avian flu or Zika, that when there is a pandemic and there is a lot of stress on health services, other very important services for women, such as sexual and reproductive health, might be discontinued. So it's very important to ensure that the sexual and reproductive health services are maintained during the pandemic. Gender-based violence, as I said earlier, is likely to increase. So gender-based violence services need to be updated, adapted to the lockdown situation, made known to be able to answer to the need of men and women in those situations. Psychological support also is extremely important for people who are going to face new situation, new role, and might have to do those, carry out those activities without being trained, and psychological support should be provided whenever it's necessary. In relation to education, we saw that women in the houses are more likely to take up the role of teaching the children, and the situation of children in the houses might lead to an increased gender-based violence. So it's necessary to try as much as possible to mitigate the negative impact of keeping the children at home. The creation of radio, television, and education program for children is important to allow children, men and women, to be able to concentrate on other tasks and for children to be occupied during confinement. Financial and psychological support is necessary in households where there are disabled children. For women and men working, support for children, for childcare is also very important. An important issue related to prevention is access to water and sanitation. So government and institutions should try to ensure access to safe and sufficient water and sanitation whenever it's necessary, and also provide access to water for hand washing and hygiene. Looking specifically at economical aspect and economical impact, as we know, impact on women and poorest household is going to be very important. So it is recommended to support specifically people who are likely to become, who are already or were already vulnerable, or are likely to become more vulnerable due to the situation, such as undocumented people, homeless, poorest people, and marginalized group, providing shelter, providing food, and providing healthcare. In many countries, government are studying or have started already to develop provision of food voucher, cash transfer, and subvention, which are very important for people who are losing their resources. Very often, those funds or those support in food are given to the head of the household. It is recommended to try to make women as a recipient of those support whenever it's possible and whenever it's acceptable socially. still in relation to economic aspect, moratorium on rental arrays, and on the disconnection of services like water and electricity is recommended to allow people to go through this economical turmoil in a better position. Whenever possible, it is important to look at possibility to allow staff to work from home without losing their salary and their beneficiary and the benefit. And with this, I would like to thank you, and I will let Professor Ndola to continue this panel. Thank you.
Thank you so much, Dr. Bagnol. Very, very important points that you remind us that of the differences between men and women. So we're going to take a few questions now, but before we take some questions, I would like you to go to the bottom part of your screen where you have the polls and respond to some questions that that we have put there. So please vote on those questions as we are talking. And so the first question for Dr. Sabra comes from Dr. Putra from Arilanga University, and asking, can we assume that males have a greater risk because of the complex immunological innate response toward the virus and its lifestyle?
Yes, so we do have evidence, at least from other viral infections, including SARS-CoV, which caused the 2003 SARS outbreak, that males do have lower innate immune responses to these viruses, and that this may contribute to worse outcomes. So your hypothesis is a good one.
Thank you, Dr. Sabra. Now, for Dr. Bagnol, Indonesia did not report disaggregated COVID-19 incidence and mortality by gender, and there are no data at all for many African countries. Are there international agreements, such as with the WHO, requiring partner countries to report gender disaggregated data?
I don't know specifically in relation to COVID-19, but I can ensure you that in relation to HIV, it has been a request to collect disaggregated data by sex. And I assume that is going to be an international requirement in relation to any disease, any situation, because more and more people internationally are understanding the importance to collect data at least by sex. And in this case of COVID-19, we understand that collecting data in relation to age or collecting data in relation to the other determinant of health, like wealth and like social classes, are also extremely important. So I would say the requirements are there. It's a problem of country doing it and collecting the data in that way.
Thank you. I'm going to ask now, Jutta, if you could share the poll results. And the question was, why is it important to integrate gender in disease outbreaks? And 83% of you responded all of the above, and the differences in mortality, healthcare worker composition, measured to prevent disease. So I think we are on the same page when it comes to why is it important. So I'm going to move us along to the next speaker, and our next speaker is Dr. Nargiza Ludgate, and she comes from us to the University of Florida.
Can you hear me?
Yes, yes.
Okay. Good morning and good evening, everybody. My name is Nargiza Ludgate. I am assistant scholar from the University of Florida. I'm representing. I will be presenting results of a recent study we have conducted in Nepal on the advancing women's participation in livestock vaccine value chains in Nepal, Uganda, and Senegal. This project is funded by Canada's International Development Research Center, and this is a 3-year project. Oh, okay. The outline of my presentation is I will tell you a little bit about the motivation that interested us in the research and the submission of the proposal, our research questions. Our research design consists of 3 phases, and the first phase is mapping the livestock vaccine value chain, and I will present the objectives of that. Then I will shortly describe the methodology that we used in Nepal. I will also give a brief overview of Nepal, as well as talk briefly about gender and intersectional issues in Nepal. Then I will present the results of our mapping and with the focus on PPR vaccine value chain. And then I will discuss the findings of the mapping, COVID-19 potential implications. We are still learning, but there are implications that we are seeing and starting to read, and how this pandemic can and the research that we have conducted can help us inform gender strategies. So there are about 1 billion farmers in sub-Saharan Africa and South and Southeast Asia who rely on livestock for their livelihoods. And the majority of these livestock keepers are women. Many fatal diseases, livestock diseases worldwide, such as Newcastle disease in poultry, PPR in small ruminants, are vaccine preventable. However, these diseases still cause high level of morbidity and mortality due to multifactorial reasons, including the lack of knowledge about existing vaccines, logistical constraints making vaccine delivery difficult and expensive, and social constraints, including gender inequalities within households and communities that limit women's uptake of vaccines. As many of you in the field probably know, that there are limited vaccine production for animal diseases in low and middle income countries, and there is a limited interest from big pharma because of unsustainable profits. And this is all complicated by the climate change issues that are creating unpredictable effect on the disease outbreaks. So small species of ruminants, particularly sheep and goats and poultry, are very important for the women. They provide a lot of benefits for women in many developing countries. They are the source of income, prestige, and food security. So the diseases of small livestock species are found to affect women more than men, since women bear the primary responsibility of looking after diseases, after the animals that are sick, and rely on the income they provide through sales or directly as food for the household. This was the motivation of our research as we presented that to the sponsor. Our research questions were developed around the central hypothesis that is, the women may increase their use of animal vaccines or derive greater benefits from participating in the livestock vaccine value chains due to a complex and interrelated set of factors that are not always related to their positionality of female. Our research is focused on gender and how it intersects with with other social markers such as caste, ethnicity, livelihood strategy, education, age, geographic location, and so forth. So our hypothesis leads to several interrelated research questions. How do gender and intersectionality contribute to a better analytical tool for understanding women's engagement in the livestock vaccine value chains? Specifically, we're trying to determine, we're trying to determine where the women are in the supply chain or the distribution chain of the vaccine. What are the intersectional barriers? What are the intersectional barriers that intersect with gender at different nodes of the value chain? Our phase 2 of the project is focused on the intervention, and we are looking at how specific interventions that we would introduce, that we are now in the process of rethinking because of COVID-19, will lead to greater women's participation in livestock vaccine value chains. And the last question is, do greater women's participation in livestock vaccine value chains will lead to greater vaccine uptake by women or higher economic and empowerment benefits? As I said, the mapping is part of our phase 1 of research activities. And the livestock vaccine value chain mapping, we designed that in a way to contribute to the understanding of how gender intersect with social markers. As I mentioned earlier, such as caste, ethnicity, in Nepal, in relation to women's access to the PPR vaccines, and how it influences the participation of women livestock keepers in the PPR vaccine value chain. The primary research objective was to map the key actors in the PPR vaccine distribution value chain with a focus on women's involvement at every node, and also look at the related attributes and perception of this involvement. The secondary objectives are to investigate how rural women and men perceived who is in charge of goat husbandry, identify relationships and dynamics of interactions at each node, whether that's individual, inter-household, or community level, identify constraint, barriers, and opportunities female livestock keepers face in accessing the PPR vaccine, with a focus on individual, intra-household, and community level barriers and opportunities. And finally, to identify which factors of intersectionality, specifically how gender intersect with ethnicity, socioeconomic class, geographic location, that are more effective to increase, that you can utilize and create opportunities to increase access and acceptance and adoption of livestock vaccines by women. The methodology, we employed a mixed methods approach. It was mostly, we used qualitative and the primary methodology was around the qualitative data collection, such as conducting focus group discussion, key informant interviews, but we also employed some short surveys. The fieldwork took place in 2019 and involved 2 phases. The first phase started early July until the beginning of August, and the second phase was started in mid-August, and we ended data collection in October. The focus group discussions and individual interviews were recorded and transcribed by Nepali into English for data analysis. Some key informant interviews were completed in English, especially those at the national level, and some in Nepali, particularly at the local level and at district level. The collected data was disaggregated by sex and by other intersectional factors, such as caste, ethnicity, age. We also looked at education and geographic location. And data was collected at the national level, provincial, district level, and community level. And in this map, I pinpointed the areas where our research sites for data collection. So before I go into the findings, I would like to give you a quick overview of Nepal. Nepal is a landlocked country, approximately the size of the state of Michigan. It is divided into 3 agroecological zones: mountains that occupy about 35% of Nepal, hills 42%, and Terai 23%. Terai is sort of located along the border with India. There are about 123 spoken languages, 125 caste or ethnic groups. Hindu religion is a dominant religion. Higher caste is represented by Brahmin and Kshatri, and lower caste usually by Dalits. One of the largest ethnic groups in Nepal is Newar. Nepal population is about 28 million. A high proportion of youth work abroad and contribute to the country's gross domestic product in the form of remittances. Most of the rural population depends on agriculture as the main livestock livelihood system. As the main livelihood system, representing potential opportunities that could be enhanced to reduce rural poverty. Livestock is an integral component of the agricultural system that provides smallholder cash income, improves dietary diversity, increases agricultural productivity through draft power and manure. Goats are the most commonly owned form of livestock. About 49, almost 50% of the households keep goats, and the average herd size is about 3.3 animals per household. In Nepal, goats are commonly referred as a poor person's cow. Women are responsible for taking care of small ruminants and poultry. The women's land ownership is very low. It stands at around 8%. Men out-migration to Gulf countries or even to larger cities within Nepal has increased the burden on women. They are responsible for household chores, childcare, farm activities, community, especially during the religious holidays and ceremonies. Intersection of caste, ethnicity, age, socioeconomic status are multiple and complex. Most Nepalis follow the Hindu hierarchical system that shapes societal structure in Nepal, that systematically categorizes people on the basis of wealth, caste, gender, and class. There are 4 major caste groups, which are categorized by occupation: Brahman as priests, Janatis as warriors, Kshatriyas as merchants, and Dalits as untouchables or service caste. Traditional practices put women at a disadvantage. For example, such practice such as Chaupadi makes mother and infant stay at home in a cowshed during and sometimes after delivery. This practice, the government is trying to eradicate this practice, but it is still prevalent, especially in remote areas. Women get married at an earlier age than men. Also, women with no education marry even earlier than women with higher education. Women, when they have a job, they earn less than men because 52% of women work, because 52% of women's work is unpaid, and 77% of men receive salary as in cash. Higher caste women have more restrictions in mobility in comparison to Dalit women. And there is even an etiquette for women from higher caste have to behave and speak in public. Okay, so now I will be telling you about the vaccine value chain itself. So in Nepal, the livestock vaccine value chains are regulated by the National Disease Control Programs, and such programs exist for PPR, foot and mouth disease, for swine fever, Newcastle disease, and rabies. In 2009, National Vaccine Production Laboratory produced about 8 million vaccines, and the production increases. About 7.5 million is for free distribution among farmers, while 500,000 vaccines are channeled through commercial, through private sector. The most of the response is to the disease outbreak. Vaccination campaigns happen in March, June, and vaccinators usually target high traffic areas such as roads, markets, commercial goat farmers, and high caste. This picture or the chart shows the flow of the vaccine as well as the information flow. It shows how the vaccine is channeled through by the government when the disease outbreaks occur to prevent the spread of the disease. So what you see in blue is the flow of the vaccine from the National Vaccine Production Laboratory to the regional veterinary labs or so-called vaccine banks that do not only store vaccines, but they also do lab work and pathological exams. There are 5 vaccine banks throughout Nepal. Some of the vaccines go to vet hospitals or district livestock expert service centers that coordinate vaccine information, train farmers, and vaccinate animals when they bring them to the hospital. But the bulk of the vaccine is channeled through the livestock service centers at the metropolitan, sub-metropolitan, municipality, and rural municipalities. And then if the cooperatives are involved, then some of the vaccines go through there to the vaccinators, who are usually junior technicians, junior technical assistants, and community animal health workers that vaccinate the goats. And in orange, you will see the information flow, which is two-directional to either report the outbreak or submit a vaccine request, and then also exchange the delivery dates for the vaccine. Okay, I wanted to highlight here that the livestock service centers within the rural municipalities represent the public veterinary system at the community level, and they're very important. There are about rural municipalities usually encompass about 10 communities or wards on average, and the head of the service center is usually a trained livestock technical agent who maintain a roster of the vaccinators. The primary responsibility of the agent is to report disease outbreak, compile vaccine requests, and mobilize communities for vaccination campaigns when they are scheduled. Okay, so now the findings of the mapping that we have conducted using both gender and intersectional analysis. The findings are organized between national level, provincial, and district level, because some of the issues and the barriers we saw were characteristics of these different levels. And then there were community level specific barriers and the findings that I grouped separately. The main bottleneck at the national, provincial, or district level, the main bottleneck at the higher nodes is related to the broken chain of command due to recent reorganization of the government administrative system from central to federal, with subsequent decentralization of power to provincial, district, and various municipality levels, including rural municipalities. If in the past the vaccine value chain included fewer actors, the decentralization created more actors, which resulted in a confusion, lack of coordination, weaker chains of command, and more red tape that hampers vaccine flow. Common issues are delays in orders, transport, and distribution causes delays in both vaccine distributed among the different actors, potentially reducing the vaccine's effectiveness and raising concerns among the livestock keepers about the benefits of vaccination. Most importantly, the vaccines often reach livestock keepers months after an outbreak or when vaccination is due. So for example, if the livestock keeper places a request with the municipal livestock service center in January, most likely the vaccine will reach the livestock keeper around April, May. There is the lack of women in the upper levels of the nodes, as well as the representation from caste. The caste system does not, according to the government documents, the caste system does not exist anymore. It has been eradicated, and the government promotes social inclusion. But in remote areas and in the rural areas, it is still prevalent. Going back to the lack of women in the upper levels of the nodes, fewer positions within the vaccine value chains are occupied by women, even under the government quota to increase women's participation by 30%. Many women fall out of the system for several reasons. One, they can't pass a qualifying exam required of all public officers, and two, lack of women-friendly policies within government institutions. For example, lack of maternity leave, educational opportunities, and so on. The situation with caste representation at the government level is even worse. Officially, as I have told you, the government eradicated the caste system and promotes social inclusion, and promotes educational and economic opportunities, but it still does not reach the lower caste, but gets more, provides more opportunities for the higher caste. for the ethnicities that have larger representation in the region. Moreover, as in other countries, the poor road and cold chain infrastructure throughout the country also hampers the delivery and the distribution of the vaccine to the livestock keepers. At the community level, the vaccinators play an important role connecting the livestock keepers with the community Most community level livestock service providers are men because of certain constraints, mountain terrain, inferior infrastructure in rural areas that complicate the movement of women. Early marriage that also prevents young women from completing school and household chores, preventing women from exploring opportunities outside their home. Literacy and numeracy are generally lower among women than men. That also limits their ability to attend technical schools and become a vaccinator or a technical assistant or junior technical assistants. However, the feminization of agriculture and livestock in Nepal, as well as remittances from abroad, are helping encourage more women to diversify their occupations and seek opportunities in veterinary services.
Sorry, Nargiza, can we speed up a little bit?
Yeah.
Thank you.
The findings from the mapping show that there is a big lack of knowledge about vaccines among goat keepers. As I mentioned already, vaccines are not available when needed. And the areas where we conducted data collection, there were goat cooperatives, and they were very important in the delivery of the vaccines, particularly targeting the women and increasing their awareness and knowledge about the vaccines. From the intersectional analysis, we found that women ownership of goats is heavily influenced by their relationship with their husbands. The closer the relationship, with, of course, if it is there is no interference by in-laws, the more freedom a woman can exercise in decision making. Women in focus group discussions reported that they control earnings from goat sales. Women are usually the first responders whenever animal is sick or becoming ill. Gender norms are more egalitarian among large ethnic groups such as Newar, and surprisingly to us, among Dalit caste, especially in areas related to marriage choice, divorce, physical mobility, division of labor, and accessibility of women's wage labor. There is a big lack of awareness about the vaccination campaigns among households which are located far from the roads and located at the edges of the communities. And what we found is that the Dalits are usually located at the edges of the community, and they usually drop out of the vaccination programs. The cultural beliefs among marginalized groups is very strong, and they often go to seek traditional healers to treat the sick animal. So the potential implications from COVID-19, we have not done any research, but we are also dealing with the implications of current pandemic, of current lockdowns, and what we are seeing is that there is an effort by the government to redirect the scarce resources from veterinary services to public health. We have not documented that yet, but we from the discussions that we had with our stakeholders in the country is indicating in that direction. In the times of crisis, gender equality as a goal that is often temporarily put on hold, as we all know. Gender dimensions tend to be regarded as secondary, but emergency responses that fail to incorporate the gender lens are highly likely to exacerbate existing inequalities between men and women, and in turn exacerbate outbreaks. In Nepal, because many wage labor are Dalits, the lockdown has affected them considerably, and thus widening the inequality with the higher caste. As Brigitte has just reported,
I'm afraid we're way over time, and we're going to have to move on, or the other speakers won't get.
Okay, I will skip the three last bullets because Brigitte has already brought them forward, and I have not seen that yet in Nepal. I wanted to emphasize that as we will develop gender strategies or interventions to post-COVID-19, it is important to collect gender and intersectional data to develop these gender-sensitive interventions. So we have to strengthen the collection of data disaggregated by sex, and also look at intersection and intersectionality, and employ the analysis of both to understand who, how, and what are affected by COVID-19. The focus on strategy should be to deliver quick aid to women and marginalized communities. The cash transfers have proved their success, and also create platforms to engage more women and marginalized groups in shaping policy interventions. This is our contacts. I'm part of a 6-team group from University of Florida. Our contacts is there. You're welcome to contact me. I apologize for running over my time. Thank you.
Thank you, Dr. Nargiza. So let's hear now from Dr. Michael T., the Vice Chancellor at the University of the Philippines.
Yes, thank you. Let me share my there. Is that good? Good. Thank you. First, I'd like to thank the first two speakers for your presentation. And as the only male panelist, I can perhaps express our appreciation for the warning that we are more prone to COVID-19. As such, we will be more careful at this time. Also, being from the Philippines and hearing about the gender inequality that is, we perhaps feel less in the Philippines. We have had 2 presidents who are women, and all our first ladies are women. Also in my university, the chancellor and 2 vice chancellors are women. So there is indeed gender inequality in favor of women. Now, the objective of my presentation is to recognize the psychological impact of social distancing on the populace, evaluate the steps that can help alleviate the psychological impact of these measures, and differentiate the effects on gender. The situation, March 2020, March 8, public health emergency, and from March 16 onwards to present, there is temporary closure of non-essential shops and businesses, travel restriction, and mass gatherings have been prohibited. So less community work, less community interaction as a measure against COVID-19. It has been noted that home quarantine results to anxiety, depression, increased alcohol consumption, and lower mental health well-being. There's boredom, loneliness, and anger. In fact, 2 days ago, we've had a shooting incident here from because a van carrying liquors, 36 cases, is trying to go through a checkpoint. So that's how home quarantine is affecting our society. But resilience is known among Filipinos. We've been described as strong as Molave and pliant as bamboo, with adaptive coping, resilience, and absence of anxiety even being correlated in situations in the community. Resilience among Filipino women is known even in Canada, where a study was made, cultural factors affecting resilience of Filipino immigrant women. Whether in the Philippines or in Canada, women are resilient. So we did an online survey using snowball technique, looking at impact of event scale revised and depression anxiety stress scale 21. This is our study with SEAOHUN, and Vipat is very kind to have assisted us here for the Survey Monkey and connecting us with Professor Roger Ho of China and Singapore. This is our survey. Look at this. Female are more likely to answer our questions. They're more engaged, and this survey happened during the time when we were reporting increasing case with fewer recoveries than death. We've had more death during this time than recoveries. So that's the kind of situation when this survey was conducted. And as a result, we noted that more than 1/4 of our population experiences anxiety, 1/6 impact of event, meaning post-traumatic stress and depression. This is the age group, no? Males are less affected in terms of impact of event, stress, anxiety, and depression. But the age group, these are the young people who are more affected. Those who are parents are less affected. We ask this because we know that those children less than 16 years old are not supposedly going to die from COVID-19, and having children more than 16 years old is more likely to push you into higher mortality. So we were surprised that having children, whether less than or greater than 16 years old, resulted to less anxiety. And the single being the reference, we noted that married and at least those divorced are less affected by COVID-19 psychologically in terms of anxiety, depression, and stress. Now, this is the result when Professor Ndola asked me about gender. So I look at whether you're male or female, single or married. Married men are least affected in terms of impact of event scale and depression, anxiety, and stress. It is the single women who are most affected with the highest scores. Being a single man is equivalent to being a married woman. Students have higher IES, stress, and anxiety, but not depression. And being quarantined. Imagine everyone is already quarantined. You cannot go out of your house unless you have a quarantine pass to buy grocery and medicine. But still, being quarantined by a health authority, meaning you're asked to stay at home by the doctor, results to higher stress, anxiety, and depression. That's understandable. But look at this. Health professionals, despite the higher risk of infection, healthcare professionals suffer less psychological effect. And we look at correlates. It is possible that the average number of hours per day that stay at home results to higher psychological impact, meaning you stay at home for 20 to 24 hours a day, you'll probably really be bored and depressed, anxious, stressed. While those who have 0 to 9 hours stay at home are the least affected. We're saying that it is probably because these healthcare workers, the frontliners, are able to go out of the house and get face-to-face interaction with others. It seems that online interaction does not replace real face-to-face interaction as a community. So satisfaction with health information also results to less psychological impact. Use of social media, on the other hand, results to greater psychological impact. It's probably because these people are already anxious. They're trying to look at all the other news, including fake news from social media, leading to more depression, anxiety. Now, the female factor, knowledge and concern. Women are more concerned about family members and more concerned about children less than 16 years old. And they are more cautious, covering their mouth when sneezing or coughing, reported more frequent washing of hands with soap and water, and think that there's too much unnecessary worry about COVID-19. It appears like women, because they are also anxious, become more careful in dealing with COVID-19. So part of our discussion says that negative psychological effects of quarantine, the duration, uncertainty, fears of infection, sense of isolation and frustration, and inadequate basic supplies. Quarantine is stressful as it prevents face-to-face connection and traditional social interactions. So part of the efforts in the Philippines would be online consultation. Philippine Mental Health Association has this USAP, which translates to talk. It is a number, 898 USAP, meaning you just press the corresponding alphanumeric number, and they came out with several infographics as well as contact points. As a final note, maybe we can say that compared to the originator of this survey, our results are similar to that of China. And while Filipino students are known to cope with abundance of available external resources that help develop emotional resilience, this circumstance imposed by the isolation and quarantine prevent one from tapping the spring well of hope. Students who have suffered Typhoon Haiyan, many typhoons here in the Philippines, getting isolated and in depressed communities, have been known to be resilient. And that is because they live in a community where they are able to still work with other people. And that's probably a reason for the married women with children to be less affected, because they have someone in their house to talk to, unlike the single who probably are living alone in their condominiums, having only online access to people. So recommendations include that mental health care providers adopt and conduct online consultation, address the majority that are able to access them. Students must be assisted, for while these Filipinos are known to cope with an abundance of available external support, that external support is not available at this time. We are all isolated and quarantined. But let me show you this. When I was listening, I added this slide saying that the Filipino are very resilient, especially Filipino women. We can get it done. And while men dominate the total labor force, Filipino women find themselves in the driver's seat, serving the natural roles of leaders, knowledge holders, and mentors. So while there is more men in the workforce, we are actually slaves of women. And with that, I'd like to thank you for this opportunity to present a unique but empirical basis of how COVID-19 and quarantine is affecting the psyche of the Filipino people. Thank you very much, and good morning, good evening, good day.
Thank you so much, Dr. T. I really apologize that we went way over time and we have no time for discussion. Jonna, do you think that we can just give Dr. Tram 1 minute to share her experience of what's going on in Vietnam?
Yes, please, let's have that late breaker, and then we will in advance just say goodbye and thank you to all who have joined us today. And I'll let Dr. Pat close us after Dr. Tran.
Dr. Tran, you are on mute.
Hello, everyone. Yep. Thank you, Professor Ndola, and organization give me opportunity to share some experiences in Vietnam. I just want to know about this seminar yesterday, so sorry I cannot have a nice PowerPoint presentation, just very short. Because of limited of time, so I would like to share more information, but I only have some minutes. So please let me experience in response to COVID in Vietnam. You might know that Vietnam is one of the countries having been successful in control COVID-19 with reportedly 0 deaths and under 300 cases of COVID nationwide. In a country, nearly 100 million people. With COVID-19, Vietnamese authority had reacted early and decisively and with a degree of severity. Prime Minister has spoken about COVID like a battle that the entire nation must unite to fight. Vietnam also implemented very tough control on travel and on people who were potentially infected affected by isolation. Very early in the crisis, Vietnam also have a quick to put lockdown and social distancing. There is no denying that these measures are in fact in controlling the outbreak, but they also have a gender and psychological impact to persons of all gender differently. There are a number of affect gender and psychological issues similar like previous presenter have mentioned. But in case in Vietnam, I also give some example. For example, on the 6th of March, Hanoi discovered the first case of COVID in Hanoi. In early morning next day, all markets and supermarkets were in crisis with no food in the south. And at the same time, the patient number 21 in Vietnam is a former chairman of Vietnam Academy of Social Science, my boss, who one of the first COVID patient in Hanoi, and our office was closed for a week in early March when Hanoi have under 10 COVID patients. And nearly 100 staff were sent to isolation hospital, and more than 300 people were required to implement self-isolation at home. Though people conduct isolation under supervision of local authority, health staff, and police. Some colleagues have to stay at home under supervision of police 20 hours per day during 14 days. And at that time, there are new COVID-19 patients in Hanoi, so they are so nervous and stressed. We also got stigma and discrimination of the neighbor and community, even though mass media. And our colleagues very stressful, and I think that's the way of local authority to force people to implement self-isolation and the community behavior influence their psychology. And there are a number of evidence to show that COVID-19 influence the gender by gender. Yesterday, I read a paper shows that high rate of school drop because of long school closed, and most of pupils who left school are girls, and the main reason are getting married. And the paper reported that a high school in the Central Highland in Vietnam, there are 30 people left school during school closed because of COVID-19, and among them 20 girls. Mm-hmm. I think, and I have more evidence here, but because of limited time, I can send you some information by text. It's interesting that in the Western countries, the rate is 20. The rate of female infected COVID is more than female, but in Vietnam, 64% infect COVID-19 is female. So maybe Dr. Phúc can have some explanation for this. My question is how the culture and gender influence infection rate. Maybe Dr. Phúc can give you some explanation later. And thank you very much for attention. So I hope that we have more time to share, but the limited time. Thank you.
Thank you so much, Dr. Tran. I apologize again for us going over time. I think there's so many more ideas to share than time that we have allocated for today, but I promise that we will continue the discussions. It's very pleasant to see the interest that SEAOHUN brings to the table when it comes to gender inequities and how gender can be sort of mapped and addressed during epidemics. And thank you so much for all of the presenters. And I'm passing back to Jonna.
And I'm passing on to my partner, Dr. Pat, to take us out.
So thank you very much for staying over time until the very end. So a round of thanks to all the speakers who share their experiences and learn a lot today. And thanks to all the participants and everyone's behind the scene to make things possible. Since we don't have time for Q&A, I encourage speakers to share their slide and put their contact information, especially email addresses, so our participants can reach out to you for discussions. So I'd like to announce that we have this type of sessions every 2 weeks. So the next one up will be on the May 21st in Southeast Asia. And the topic will be on the diagnostic testing approaches for COVID-19. So hope to see you in 2 weeks. So any last words from Jonna?
No, I think Bruce wants to do some housekeeping so that we can all do our QR code to close us out. Thank you to all the amazing speakers.
So thanks everyone, really wonderful presentations. And just want to remind people that would want CME or continuing professional development credit, there's a link in the chat and in the announcement, and we really look forward to your feedback, and you will get instant CME. And for those using the PDA participant app, please scan the QR code to complete your attestation, and you'll get instant access to the presentations and a certificate. And I will stay on if anyone needs help with the PDA. But with that, we'll bring the formal close to this wonderful session and look forward to seeing everyone in 2 weeks.